Okay, so yes, Thomas, you have asked. And as I said before, we're only doing high miss questions, and some of them I've actually given to you without necessarily saying, okay, so these were the high miss questions. Does that make sense? But which others? No, I can't hear a thing. Can you guys hear him? Hold on. Let's see. Maybe. Nope, my volume's up on 40 something. That's weird. Can you guys hear me?
Yes, ma'am.
Okay. So I don't know why I can't hear him. And truly, I am not being funny. This is starting to stress me out.
Can you hear this, Ms. Hudson?
Yes, I can hear that.
Okay. That's all.
I can hear you. Yes, yes. I was like, I can't hear him. I felt like I was being punked for some reason. I was like, what's going on? I can't hear him, I promise. And then I was like, he probably thinks I'm like lying, but I can't hear a darn word he's saying. Sure, we can do that. That's not a problem. I was like, which rest? What do you mean? We can do it in the QA session. Mrs. Smith has the last 45 minutes of you guys today. And if we have time, I will do some more. So I don't have a problem with that. But she does have the last few minutes, so I don't want to chew up or into her time. But I will say this though, and I think I said this before. Um, you know what? We'll just do it now. It's easy. So, question for you guys. So, tell me, if you receive a patient that requires epinephrine for anaphylactic reaction, what other medications will your patient receive? Okay, so I like that. Diphenhydramine, yeah. What else?
Corticosteroids.
Okay, so corticosteroid, what else?
Ranitidine.
I need to mute their mic or something because there's a extra background noise, so I feel like I'm in a hollow space. And what was the last one? Last repeat? H2 blockers. Okay, that would be. Okay, give me an example of an H2. H2, and I said blocker, but H2 what? Because I may be giving you the answer versus you giving me the answer.
Antagonist.
Okay. It would be an antagonist. Thank you, Luina. So give me an actual name of which would fit this H2 antagonist or blocker. Like the name of a medication, a common medication, not something
Zantac.
like Zantac. Okay, so those would be, you would do H1 and H2 antagonists. So you would do diphenhydramine, you would do something like Zantac, and then you would do a corticosteroid. So for some reason, what's the other word for Zantac? Famotidine. So either, okay, ranitidine. What's famotidine? Pepsid.
Yeah.
Okay, so those are two common other H blockers, histamine blockers. So we have those we have the diphenhydramine, which is Benadryl. We have ranitidine and we have famotidine. So those are the two commons that were given. So on the exam, there were a lot of non-selection of famotidine or your H blocker, your other H blocker. Does that make sense? So it's as if you chose 2 versus choosing 3. Yeah. Go ahead.
So my question isn't about that, but it's about the Q&A. I have on my calendar that it's on the same day as the P&C exam. Is that still the case, or did one of them move?
Actually, what I thought he meant by Q&A is the Zoom session on Saturday.
Oh, okay.
But that is true. The Q&A was scheduled on your class day from, which would be 8 to 10. What time is your P&C exam?
My calendar, it says 11 a.m.
Okay. Is that not doable?
If they don't overlap, I guess it is.
Okay. I'm meeting with Mr. Bobbitt anyway today, just because there's been several questions about that, but I think his last response to an individual was that it's at 11 o'clock. So I have Q&A with my bridge students on Tuesday. I mean, we could do Q&A separately, but when I mean separately, but just not on that day, but a different day. But it's best to do it early in the week. That gives you more time to review information later. So I don't want to do it too late in the week. Does that make sense?
Yeah.
I don't have a problem moving the time.
No,
But
what is
the
time though? Because I have it 9 to 11 on my calendar.
Okay. So you want to leave it at 9 to 11 because it still doesn't encroach. We can start a little bit earlier. You do 8:30 to 10:30. So that way it gives you time in between. Just let me know what you guys need so I can help you.
Okay, yeah, I mean, it doesn't matter too much to me as long as there's time in between that we're not late for the exam.
Okay, not a problem. We can make that happen. Was that your question?
Yeah.
Okay. No worries. Then I will get with Mrs. Johns. I think she's available at the same time, so we should be A-okay.
She asked, or somebody asked in the chat, can we do it after the exam?
If Mrs. Johns is available, I don't have a problem.
Okay, yeah, because I think it would be better to do the exam first, so we're not worried about that, and we can really focus on the review.
Yeah, I can see it. I can see the question. During Q&A, we'll be going over the highly missed questions. We will not do it for exams 1 because that was already done. I think half of the people received their one-to-ones before Corona hit. So we may do highly missed questions for 2. I'm doing 3 now, so this should cover that. But, those questions won't be the same. So, I mean, it's better for you to understand the content versus trying to memorize a question. So I'm just trying to help you out here. But it's more the content that's being missed. So just, knowing that we have different H2 blockers, we have different H1 blockers, and what they are, what are our most common ones that we see in practice. It was decided by the powers above me that we would not be doing one-to-ones. So I don't know the exact rationale, but I would probably say if there's been some impropriety or lack of integrity along the way, then they took that into consideration, whether it was your group or not. So that could be the only thing that I can personally think of. But I have not heard from anyone directly saying this is the exact reason why. And even when you do the one-to-ones, I think some of those weren't being done to the expectations of what was set forth. So there was some issue there. So let's see, Kristen, you asked the question about So let me go back. I went to the next one, by the way. That answer was there, but that's not one that would be used to treat to treat anaphylaxis. So and the reason being that is in the anti-inflammatory, that this is more to block the mediators. So blocking the mediators would actually stop some of the that would stop the progression, not the progression, but the additional introduction of new anti-inflammatories. But that's not, if you give the others, it's stopping the histamine, and the histamine is the thing that's triggering the anti-inflammatory process in the first place, along with the reaction. So if we stop the reaction, then we should stop the other piece without necessarily having to give that. Now, maybe later down the line, but this was to block the mediators that cause the reaction. So here we would be treating a symptom of the reaction. Does that make sense? Okay. We'll see. We'll look at the Q&A for that following week, but we'll try to cover all the exams with the best integrity that we can. The drop date was officially moved. That is correct. That was posted in, and that applies to everybody, not just certain folks. That was a district decision. I know. I'm sorry. I hate to be that thorn in your side. I know what you meant. And you know what? We're struggling. Even I'm struggling, but it's all good. No worries. So let's move on to this next one. So, question for you guys. What are things when you have a patient that has MS, what are things that we should focus on to, help them with their care? All right, fatigue, quality of life, safety, comfort, pain. Okay. All right, so when you say quality of life, are you speaking, what do you mean by quality of life?
Do you mind if I just use audio? It's just faster.
Yeah, that's fine. I don't have a problem.
I would just say making sure they're getting the most out of their everyday, because no one case looks the same. So they might progress rapidly. They might progress, over 30 years. So just making sure them maintain their ADLs and independence as much as possible, so that whether they are having issues with pain or mobility, you're just making sure of that.
So basically self-care is what you're talking about. Self-care. And the ADLs will be a part of bowel function. Making sure that their bowels are good. They don't have any issues there, because what's the problem with multiple sclerosis? What's our issue? Demyelination. So that means, besides the progressive, which is true, it's the demyelination, which means at some point those neurons are not going to be functional. So it's going to start affecting all areas of the body. So making sure our eliminations are good, making sure that the patient we're promoting self-care, that we're looking at mobility, we're looking at avoiding injury, we're trying to make sure that they do achieve as much bladder and bowel continence, not incontinence, but continence as possible. Looking at their speech, looking at swallowing, looking at their cognition function, looking at their coping mechanisms, looking at their sexuality. Are they having sexual dysfunction, and how can they adapt? Looking at their home maintenance in general. So, avoiding fatigue, not getting stressed, having stress reducing strategies. So all of those are things that you would, focus on for a person that has MS. If you have a patient that's on corticosteroids and they have an illness, should they or should they not increase their dose? or talk to their physician about increasing their dose. So I should say, should their dose be considered to be increased during that time? So we should, talk to the patient that if you get sick, you want to call your physician, talk about increasing dosages ahead of time. So that way, they're going to be at a deficit. They won't have the availability of that corticosteroid when their body's under stress. So during that time of stress for only a couple, 2-3 days, then they would increase it until that illness is kind of tapering off, and then they would go back to their normal dose. So they should talk to their physician about that. And technically during that time, no matter which illness you're using the corticosteroid for, they should at least have the conversation with their physician to increase the dose. If they've already had it, then the dose should be increased at that time. So that should be one of those, hey, if you get sick, then just make sure during the times of illness that you take an extra tablet. This would be okay. But if they haven't had the conversation, then this would be something that they should have the conversation about, because now they won't get the effectiveness of the corticosteroid. So that should be something to at least be a topic of discussion. No worries. Okay, so looking at a patient that has colitis. So they're looking at instructions for a low residue diet. So this is, what is a low residue diet? Because if you have colitis, do you want to give them things that's going to, increase peristalsis? So when we're looking at low residue, and this is from second semester, or maybe even first, then we're looking at, lean roast beef, white rices, teas with sugar. So we're looking at things that's not going to irritate the stomach even more. Okay. So when you say low fiber, low fats, make sure that you know what the low fiber, low fats are. So like examples of that. That would be the thing that you would be focused on, to make sure that you're not giving them the wrong thing. But refined cereals and pastas, vegetables without the skin. So they can do vegetables but no skin. Once it's well cooked. Bananas that are ripe, cantaloupes, watermelons, they're things to that they can have. White bread with no nuts or seeds. So those are examples of what low residue would consist of. Would caffeine be a part of that? No. So those are the things that you would stay away from. But you would try to stay away from those, but they may allow like decaf at some point. But you have, plain cakes and cookies. Those are things that they could have for fats, because someone said fats. So that would be like your plain salad dressing, your mayo. You have options. Potatoes, you could do those. Sweet potatoes, white potatoes, as I'm going through your list. You have certain soups like the bouillons that can also be utilized. Then some certain herbs. Interesting, bacon, you can do eggs. You can do cottage cheese. So, but you can't do things like pizza or hot sausage or wild grain rice. You can't do the potato skins. You can't do oysters and clams. So you just kind of know what, it's a little bit more than the brat diet, but just kind of have an idea of some meats. So like, lean roast beef would be a definite one. And then your book also lists, as well, other low residue type foods. I did say meat because one of your options was lean roast beef. So crisp bacon, well cooked and drained hot dogs you can do, or frankfurters, but you can do lean meats. All right, so there was do patients that have multiple sclerosis, why do we have difficulty treating these patients? That roast almost got me. Okay. Why do we, why is it difficult to treat patients with multiple sclerosis?
Because
Yes. So it's because of, they can go into remission, they can go back into an exacerbation. So it's the fluctuation of the disease process. So it's going to be hard to kind of evaluate how effective the drugs are, because they can actually spontaneously go into a remission without you even really understanding, was it the medication? Was it, rest? What was it that actually precipitated this process? So, just kind of food for thought there.
They're usually on a lot of medications as well, right?
Yes, and so you don't know, again, which one's actually working the best, especially if it's a combo. Is it because of the combination? What is it? Hold on. All right. So let me see, make sure I didn't miss a question. Okay, no, I didn't miss a question. All right, so moving on. All right, so I know I covered this, but for some reason this wasn't understood or something or another. So what we're going to work through it. So when you have a patient that already knows they have a condition like, rheumatoid arthritis, and they're going to have inflamed, joints, and they're going to be tired, and, they know that this is a part of the disease process. What do you think a mother's ultimate concern would be? Just a mother. It's going to be the concern for her. How is she going to manage her kids? She understands she's going to be tired. But if you are a stay-at-home mother and that is your role, then you're going to be concerned about being able to fulfill your role, not about the fatigue. You've gotten that part down pat, because this comes with the disease process. So when we are talking to patients and we know they have a condition, we might want to ask the question, so for clarification, are you more concerned about how you're going to take care of your family and, fulfill your roles? And then if you're not sure, that would be the place to start. Because if I already know I have a condition and it's going to make me tired, which I do have a condition that makes me tired. So my concern is not if I'm going to be tired. My concern is, can I get all the things that I know that I'm supposed to do completed and still not tire myself out completely? Because I have leukopenia. So I know there's not a whole lot in a day that I can really do. And if I don't take those rest periods, at some point, my body will just say, we're going to rest for you, whether you like it or not. And it will happen at a time that I probably don't want it to. So just, in all, when you have patients with these types of conditions that they know they're going to be tired for, and they're expressing a concern about their role, their needs, their family, then those will be the things that we're going to ask or focus on. These are things that can help you, work through these stressors, or, managing your family better. Speaking about rheumatoid arthritis, we have a patient that has, they're complaining of pain. It's, it's not a real high number. We'll say it's 4. What things can we discuss? Interventions. What interventions could we do to help facilitate comfort? Okay, the warm shower, because the other have that issue. What else? Okay, range of motion. Okay. And when you say range of motion, are you talking about active range of motion, like aerobics, or are you speaking more of water aerobics? Okay. Low impact. Okay. So like yoga. Okay. Anything else? All right. We can use diversion techniques. I would say tactics, but that's not the right word. Techniques. Okay. What else? So in that diversion, could we use like relaxation techniques? Could we have them do things like that? Pillows for comfort. What about a TENS unit? Okay. A TENS unit would be perfect for managing that as well. For some reason, you guys didn't like TENS unit. So but TENS would be a perfect fit for someone to help manage pain. All right. Yeah, although they don't, I would, I don't see why it would not be safe, Elsa. But if you're concerned, then talk to your physician about it. But it's just basically helping to relax the nerve or the muscles. So if you're concerned, talk to them. Whether you see patients or not, or folks that you know that have it, they say they don't work. Okay. I don't know. I've used a TENS unit. I don't have RA, but I've used a TENS unit and it works. I think it depends on what they're actually trying to achieve. I know it's inflammation of the joints, but I think when you're moving and you have movement altogether, if your muscles aren't tight, even though your joints are sore, if you're taking medicines for that, you can actually help, because it's the same thing like exercises. Because when you're exercising, you are actually using muscle movement and strengthening those muscles. So even with water aerobics, they're just easier on the joint. So they do help with they may not help people you've spoken to, but it can be used as a methodology to help with the movement. There you go. Check out Ashley looking that up. She goes, thanks, girl. I love it. All right, so since we're talking about RA still and non-farm, give me some other non-farm things that can be done. Yes, it's more of the function. So what other non-farms? Heat and cold therapy. Okay. Can we use any assistive devices? Could we use like a splint? Would that help them? Like especially in the hands. Okay. What about things they could do for clothing? Velcro would be perfect. So no buttons, or something that's a pullover, so that way they don't have to do that. For massages, that's not really recommended for. That is not a recommendation for non-pharmacological interventions. So their supportive measures would be things like, we should not, basically the reason why we don't massage it is because it can actually aggravate the inflammation. So we don't massage the joints. But looking at they can seek out physical therapy to give them specific exercises that are therapeutic to prevent further loss of joint function. So, but using a splint would be an option to, especially for the hands. Yeah, physical therapy. All right, anything else? All right, so switching gears a little bit. So let's talk about major depressive disorder people. So that when they are given a medication, then what things should, when you're given any patient that's getting a psych med, what are some things patient teaching we need to tell them? Okay, it's gonna take a few weeks for it to work. Take it. Okay. Sticking to the program. Risk for suicide. Okay. What about can they just don't stop it abruptly? Yes. Because patients feel, oh, I'm feeling better. I can just, I can stop taking it. So can they do it on a tapered process? Okay, so they would need to get with their physician about that. They can do a tapered process. Okay. So those would be some very good things to include in the teaching. So making sure that, you don't stop it abruptly. It's going to take several weeks to work. It can induce suicidal thoughts and make the depression worse. We don't know. It's a test we're trying to see. If you're going to taper it, you need to do that with the supervision of your physician. So that would be the appropriate thing to let them know. Because if they stop taking it, then they can end up with withdrawal syndrome and headaches and tremors and all of those things. And that can last for about 3 weeks. So just making sure we understand when we're giving psych meds what we need to do. So if you have a person that, since we're still talking about psych, and they say, hey, I just don't like anything what I'm doing. I don't have any interest in anything, I got some trial medication from a healthcare provider last week to help treat depression. So previous history is the patient is bipolar, and they've been hospitalized prior to with manic episodes. So how should you respond? What kind of special care or concern would you have for this individual if they are taking which category of medications? Because this would be now combo meds. So the person has bipolar depression. So you think about what medicines we would put on there and what medication would actually be where we would have to have concern, the most consideration for, intervention. So usually with bipolar, they're treated with the mood stabilizers and benzos. They can be on a short-term basis. They give the benzos until the mood stabilizers kick in. So what class of medication should we not think? Avoid SSRIs. So that is correct, Jessica. Avoid the SSRIs because this can actually make their mania worse. So go back and look at, your medications. Group therapy for kiddos diagnosed with depression. So in that group of folks, what behaviors would you anticipate that group having? Yeah, irritability. So you're doing a group therapy with kiddos, we'll say teenagers. So they're being treated for depression. So I'm asking what behaviors would they have during the group? So we have irritability, correct. Not focused, okay, so like anxiety, all right. They may bully others. They may do that. So suicidal thoughts, I think someone put that there. Or did I misread that? Let me scroll back up. Nope. But suicidal thoughts, irritability. The question is, we have group therapy that we have students, or not students, but children, teenagers. They're in a group. So they're now doing group therapy. They're all depressed students, or depressed. I keep saying students, but I mean patients or kiddos. So in that setting, when you have those folks put together during a group session and they've all have depression, then they'll have a lot of anxiety, especially, I don't want this person to know that I'm suffering from depression. That will be one thing. Irritability would be another. They may have somatic symptoms. And for this group, because of all of what they're going through, and now you're in a group of people, even though you all have sharing the same thing, it's that stigma of, can you not get your life together, so to speak. They may now, contemplate suicide at this time. So think about the age group that you're talking about, where appearances is very important. Image is very important. Exactly, shame. All right, so you have a client with recurrent depression. So the nurse has kind of put together that this patient has the potential to commit suicide. What would be some contributing factors to the person considering suicide? This is more just people in general, not children, just anyone that has a history of depression. How do you know that they're contemplating thoughts of suicide? What types of behaviors would they display? How would they feel? What would be some signs and symptoms that you would come across? Okay. Sudden burst of energy. Okay. Oh my gosh, yes. Get rid of their belongings. So, they may feel guilty. They may, if they have a debilitating disease, they probably feel like they'll probably contemplate suicide. Impulsive behavior, so that getting rid of things, spending a bunch of money, buying a new car you can't afford, giving things away, saying goodbye, yes. What about anger? Especially if they have a debilitating disease, like if they found out they had Parkinson's or something like that, that over time they're going to get to a point, or ALS or something of that nature, then that would definitely amp some things up very quickly. All right, so we have a person that has ingested Tylenol in an attempted suicide, or attempted suicide using Tylenol. So what types of things would be a part of the patient's plan of care? Detox, suicide precautions. Okay, one-to-one care, pump in the stomach. Wow, that's all. I'm telling you, times are hard out here. It is rough in these streets. So certain things you could do, definitely when they first get there, you want to inventory their items, because we don't know if they have anything else that they may try to facilitate. Ask family and friends about any firearms at home. That could be an option. Suicidal thoughts. They're depressed. Do they still feel like they want to go through it? Strings, ties, shoelaces. They would probably have a gastric lavage and get activated charcoal. So that all that part's true. But once they discharge, we still got to think about when they get home as well. Or do they still want to harm themselves? Belts, plastic silverware, and even that has to be, checked to make sure that this is not an option to help them facilitate. Get them to look at their grooming and bathing and things of that nature, so that way they can, maybe if they can see themselves positively, that it would kind of shift them out of that role. Find out why did they, what was the rationale for taking the Tylenol? Making sure they don't have any other medications hidden away or squirreled away, like underneath their tongue. So our primary concern, if they're having suicidal ideation, is to look at their safety. Do a detailed inspection to make sure the safety is, implored and eliminate any options of them actually, doing or facilitating suicide while they're in the hospital and then afterwards. So there's a lot of residual things to do. Yes, support groups would be great, but again, let's flip that to an adolescent student. If this is an adolescent, this is going to be a little tricky. So, we still want to give them support groups. They're still going to go through some things that, guilt and shame and things of that nature. And then, again, get back to the why did they feel the need that this was the way they wanted to go. And if their family have, firearms at home, those would be things they probably want to eliminate, and locking that up in a safe and, putting the key somewhere. I mean, truth be told, if that kiddo really was serious, he would search high, or she would search high and low for that firearm. So it'd be better just to remove it completely, so there's no access at all. And if you had a key, leave the key at your office, but don't let the person know that, hey, I left the key at the office. But I would almost leave it in the office and put it in a safe at my workplace, just the keys, not the firearm. So, there's a lot of post-discharge things to think about as well. yeah, I mean, this was, I mean, you never know with the person sitting next to you what their life is like. They could be literally going through the biggest drama of all time. So it's kind of hard when, because you're like, oh my gosh, I didn't know this is what this person was going through. So, having some civility to a fellow person is always a great thing to do. But even with COVID-19 and people losing their jobs, or even just being on the front lines and watching people come in and not survive it, and you're wondering, like, if I get it, will this be me? I mean, there's so many thoughts that start running through your mind. And then the same thing for those people. It's easy to get depressed. Will we ever get out of this process? Just to hear that China's starting to see more cases resurge after they, supposedly opened up the country. I'm like, oh Lord, here we go. Exactly. They did lie, but I'm just going to move on. They did lie. So does that kind of make sense? Kind of putting it all together, some things. It wasn't just one section. It was, it was several sections of, between immunity and mood and affect that, there were issues. I know it got a little depressing, so I get it. And then we're getting ready to talk about death and dying, so this doesn't really, doesn't lighten up the mood anymore. But it is a part of life, and it's a part of nursing, and it is just where we are. One last thing that I'm going to mention before we break is that the treatment for ulcerative colitis. So it's not really the treatment, but it's more of, when you have a patient that has ulcerative colitis, besides the severe diarrhea, what other things would you expect to happen in that disease condition, from labs to internally in the body to diagnostic tools to be done, things of that nature? That question, I guess there was a lot of all over the place, so to speak. But just understand that, with all that diarrhea and bacteria, et cetera, they can actually end up with a toxic melanocolon or megacolon. Knowing your lab values, like 5,000 to 10,000 is your white cell count. So if you have an infectious process, then you would always anticipate white cells being greater than 10,000. Okay. Those folks would get a colonoscopy, and what would your CBC results, your hemoglobin, and what would your albumin levels be like? So those lab values that are associated with that disease condition, what would those numbers be? So that way you would know that this is all a part of your clinical picture or your patient picture for that disease condition. So it would be not just during that time. What are their risk factors? What's a complication? What are the labs? Any teaching? So if they're just asking about interventions or management or things you would find overall, and they're not specifying a specific area, it would be everything that's associated with that disease condition. So the question asks, which of the following would the nurse anticipate with this disease? So this would be from start to finish and everything in between. Does that make sense? It wasn't necessarily with an active. It was, what would be a risk factor? What would be a common complication? What else? Could they have a perforation? Could they have hemorrhage? So you'd be thinking about the whole piece if it's just relating it to the disease itself, not necessarily one piece of the disease. Does that make sense, Catherine? Okay. Louina, I think there were some things posted out on Community Methodist. I know we're looking for some nurse externs, so you might want to go ahead and check that out. I remember posting that probably about 2 or 3 weeks ago. Oh, dang. Okay. Hang in there. They asked us to put it out there. So, just give them some time. All right. So any other questions? That's true. So let's talk about, complicated grief. What would be some signs and symptoms of complicated grief? Yes. Trying to see what you mean. Do you, hold on. Hang on. That wasn't a highly missed question. Because if I'd start giving it for you, I want to know what I missed on this one. But that was not a highly missed question. As I'm going back through. Because I'm making sure I didn't miss any that were. Or you wanted me to answer that or just stay silent? Or would the answer just being tossed out to say, is this one it instead? It was glucose. Okay. All right. All right, Miss Louina, you're right. This goes on longer than it should. So everyone in your entire life, you're actually going to experience some type of grief related to some loss or another. And, that loss could be job, the loss could be family, loss could be friend, it could be your pet. So, you're going to be sad. You're going to mourn that process. You're going to cry about it. You're going to, remember the good times of that particular individual or your pet and things of that nature. So those types of things are things that, they're normal. During a certain time of the year, most people are kind of sad, which is more during the winter. And that's a seasonal depression because it's more dark and it's gloomy. It's dark literally almost all day. So, the sun starts going down about 4:30, 5 o'clock in the afternoon. And even when you get up at 6, 7 o'clock, it's still, it's 6 o'clock for sure. It's still dark outside. So, during that time of the year, you have that, oh my gosh, I just need some sunshine and I need to last longer than, 5, 10, for 10 hours, I need more than that. So, just that's normal grief. But when you have complicated grief, this is usually, things that, it's a distress that's right after, bereavement, and here the person's angry. They have this excessive stress. They're feeling dazed and confused, almost like detached from, some folks have described it as an outer body experience because they were just so detached from their environment. Painful memories, can't accept the loss, searching for the deceased person. When my dad died, my nephew would go back to the room that he was in there, and there was nothing in there. The bed and everything was, had been removed. And so he would be back there talking, and we were like, who is he talking to? And CJ would say, I'm talking to Grandpa, and we're like, it's like, we don't see anybody. But, that was where he had gotten accustomed to seeing him. And interestingly, little kids do see these, see their grandparents and loved ones after they pass. So, yeah, they can't enjoy life. They can't get back to positive experiences. It's super traumatic for them. So, I mean, this would be that complicated grief, not just the, you go through the Kubler-Ross stages and then you move on. It's the person that's 2-3 months later and they are actually in this process. I can't tell you what the appropriate time is because that's going to be individualized. But what I can tell you, a very close friend of mine, when she lost her daughter, gave birth to her early. And then basically when she gave birth to her, they told her she was going to die within hours. So Erin, she mourned Hannah's death for, and this is no lie, 8 years. I mean, I didn't know what else to say. I had run out of words. And so it was just something she had to work through. Yes, Jessica.
So I'm a little confused with the stages of grief. Is it true that you can regress and go through them out of order, or do people usually go in order?
Absolutely. And that's what makes those stages, it's not a linear process. It's fluctual, it's fluid. And you could start off with the denial and stay in denial and then get to a point that you start bargaining. So you skip a stage or two, and then you can go back to, if you're bargaining, it's not working, then you get angry. Does that make sense? It's a fluid process, and how that happens, it varies from individual to individual.
Okay.
So yeah, it is definitely not linear. It's not, you're going to hit here, you're going to hit there, you're going to be there, you're going to be there, it's none of that. It really is.
Would you say that grief would probably be complicated or inhibited, I guess, for them to reach acceptance if they did not meet all of the stages?
I can't say it would be inhibited. I would say the grief is still there because they're somewhere in the process. And until they get to the acceptance part, and that may be a year later. Mm-hmm. I mean, but this is that complicated grieving process. Do you see what I mean? It's not, for my friend who grieved for 8 years, and she finally said, "Who grieves for 8 years?" And I said, it was a process you had to work through. I mean, it wasn't for me to tell you that you had to move on. So, people say that, your parents wouldn't have liked, or your father, or this or that, your mother would not have liked it. But the problem is, if you're close to that person, it is a process that you have to heal in your mind for every stage before you can move on. But patients get to these pieces, and sometimes you don't really have a lot of time to work through stages. You may go to a facility or to see your loved one, and you're expecting, okay, they had some abdominal pain, and there's a lot of things that this could be, and then you hear that this is a 7-centimeter mass, and it's huge and in depth and this and that, and the person only have 30 days to live, and then what do you do with that? So even with the knowing, if they don't do, say for instance, they don't do any treatment, they have 2 months. Okay, if they do treatment, then the best I can give you is 4 to 6 months with treatment. So that'll be that palliative care. So they'll do some treatment to try to extend the person's life to some, it's not a quick and they're done. But again, it's not our decision. It is the person that this is going to impact the most. It's their decision. So you have to look at grief as a continuum. Does that make sense?
Yes.
Who lost a son 25 years ago, and she's yes. I mean, some things are a lot. There's just much harder to swallow. And it depends on how the person died. It depends on, the quickness, or if it was something that was long and drawn out and they suffered forever on it. It's very difficult. So, think about like part of this process is, when you like Lou Gehrig's disease, you don't know if this is going to be quick or how much time. And you have people like within a year, but they're tracking their course. And then some people, they go faster than a year. So it depends on the person's grieving. Yes, everyone's grief is different. And it does hit you like a brick wall. Sometimes you are at a stopping point. You don't even know where to move. So if you've never experienced that on that level, when my grandparents died, okay, that was sad. But then you flip that to parents or to a kiddo, it's completely different. So it's hard to understand because then you have a different level of grief. So it's not like you're at the point that you can accept it all, because some of those feelings are just overwhelming. I mean, you're getting chest pains in the middle of it and you're like, okay, am I having a heart attack, or is this like grief, or, what is it? So it is a lot to deal with. And especially if your coping skills are, how you cope with stress is not organized. So that's another issue, another reason why folks have issues as well. Okay. So, coping skills plays a huge role, but you know what? There's just some things you're just not prepared for. And that's the uncertainty. But just understanding that grief becomes more significant when they are just excessively stressed and disbelief, and they have this depression, and they, it's the person who just crawls up in the ball and stay in the bed all day long, and they just can't even move. It's like, I just can't even move to the next piece. So, trying to get them to talk to somebody, because even doing that person is now like, why do I need to talk to somebody? I don't want to tell somebody that I can't handle this. So that becomes another stressor. So, the goal for these folks, is to try to make sure that we can communicate their feelings, regarding the loss. What about it really, touched you so much, and then help them with coping behaviors and coping mechanisms and support systems. So just sending a friend, a card and say, hey, I heard you had a loss and just thinking about you. So, and most people don't like to admit they need help. I mean, that is, I don't speak for every Black person, but I could tell you in overall in a Black culture, that is just not something you do. So you'll see it won't be something that they would run to. It's just not easy. I mean, there's embarrassment, there's, guilt, there's shame. There's a lot of pieces tied to that. See, look at this here. And this is what I mean. And just for somebody to share it, it's even that. I mean, that's a huge step. So, yeah. It's a lot. Grief and dying and all that is a lot for sure. So our role today is to look at, and yes, culture does support. Yes, culture is a huge impact on grief, because, as I said, it is. I can tell you, not my grandparents, and I know if my grandparents didn't do it, no one before them, for every loss that they had, they did not go to. They didn't do group therapy or any therapy. That I can tell you. Even when my brother died, and this has been over 20 something years ago, my mother never went to therapy. It would have been helpful, because that was a significant loss, because it was her firstborn. And it was a lot of, she had a lot of emotion about that, at her time in her life of where she was at this particular point. So, I mean, I wasn't born, so there was nothing I could say to her. But I know she didn't do it. But she grieved my brother's death. It was probably about 10 years. And I don't think she still got over it. So you can't tell somebody to get over it. She still moved on with her life, but there would be times that she would check out. And I knew exactly why. Enlist the help of a social worker. I mean, you can, but the patient has to be accepting of it. So if you see signs and symptoms of depression in the hospital, you just don't let the patient be that way, but you do, you get the social worker involved. And some people do the chaplain, but they really need a psychotherapist is what they need, or not a sociologist, psychologist, that's the word. The patient has to be ready. I do think how the person dies is going to play a role. If this was a murder, a suicide, these violent deaths, sudden deaths, unexpected, you're left with, I didn't get a chance, you're left with not being able to say goodbye face to face where they could hear it. And that's where that becomes more of an issue. Exactly, Jennifer, no closure. So when you're looking at folks that have, these terminal illnesses, a very dear friend of mine, her dad died, and she didn't even tell me, which really got me. I was like, she's like, I'm so sorry. I was just so overwhelmed, and there was so much to do. She says, and it was only 10 people literally at the service. So, it's kind of, she was like, and I knew, that everybody would want to be there. So we just had to keep it under wraps. But he had heart and kidney failure is what he had. And, I knew a couple weeks back, she was like, well, we just put him in hospice. I'm like, and this was before, right as Corona was just getting ready to, we were starting to do the shelter in. So when you're looking at palliative care, this is going to be based on the patient's diagnosis. And so here we're going to give some treatment. And it's not necessarily to fix the disease. I mean, if it happens to, so be it. But they're more saying, this is going to be a short amount of time left for this person to move. And they were still doing treatment. So they were treating his heart failure. And you can even move this to a cancer patient. They may do chemotherapy or radiation therapy to see if, to prolong the person's life a little bit. It doesn't really cure it, but they're just trying to give them an extension on the previous, time frame that they laid out. But this gives the person also time to organize their finances, to organize their household. It gives them time to work on those things, and then kind of, get everyone else sort of prepared, for lack of a better word. But it's, they're doing systems management. They're trying to make that person's life quality as best as it could be for what they can have or do at that time. Does that make sense? So it's not necessarily, it's basically dying with dignity versus, well, you know what, this is a lost cause. We're not going to worry about it. We're going to move on. It's not that. It's more of continue to do what you can do up until you can't do it anymore. And I'll use my dad as an example. When he got the diagnosis, it was literally, if he didn't do chemo of anything, then, we were looking at the guy said barely 4 months. If he did the chemo, it'd be 6 months. Well, that would give him more time to do things. But some people don't want to do chemo because of how chemo makes you feel. There's a lot that goes on with the whole chemo process. It's not just get chemo and then you're like happy-go-lucky. It's nothing like that. So it seemed as though, and it wasn't seemed, the chemo was working. It minimized the masses in the different areas. And then the 6 months came up. There was nothing. Everything seemed to be A-okay. But then we hit the next year, and then they found one spot on, it was like one rib bone. And once, cancer's in the bone, that's very hard to eliminate. So things kind of moved on. And then by the time, it was almost up to a year. So when we hit July of the following year, we hit a roadblock. Because now there was nothing else they could do. None of the treatments they were doing were working, and the disease was progressing more than slowing down. So, but we had time in between then to get obituaries ready, his finances taken care of. We had all that pretty much set and ready to go. So he actually knew what he would, what his casket would look like, his obituary, what it would say, because he helped write it. But some people aren't ready for that either. So, there's so many pieces to that piece. But I do, the palliative care where they're trying to let him do things that he could do. And I let him walk as much as he could walk. And then when he couldn't walk, then I, wheeled him around in a little wheelchair. And then when he couldn't do that anymore, then I had a Hoyer lift. So I Hoyer lifted him around. I mean, we just went from one stage to the next stage. But he could still turn and help with certain things. But I didn't just well, I'll just do everything. So you let them do the things that they could do. Then you look at what are the goals of the care. Start that plan. Look at, where we can progress from here, what would be the next steps. Yeah, we did all that. And my cousin did the same thing. She did the exact same thing when her mother was about to die. She did the exact same thing. And I don't know if you all have ever written an obituary. That's stressful because you're going to remember all the stories your parents told you, what schools they went to, people that they knew, and the people that died before them. You got to remember all that stuff, get names and spell them right. It's a mess. And so, you're hoping somebody has as much information or a little bit more than you do, because otherwise that could be another standstill. So him helping was fantabulous. Other things that you want to look at is, even though palliative care does encompass end of life care, it is much more than that because we're actually treating the symptoms. They're using social workers, dietitians, pastors, support groups. They're doing all of those pieces. Advanced directives is a little bit different. We want to talk about that in just a sec, so hang on. Spiritual needs, psychosocial needs. So that's what the palliative portion, is going to focus on. Now, advanced directives is a part of that palliative. Is that what you're saying? I think that falls under the advanced directive. Which part? I must have missed something. Okay, so if there isn't already an advanced directive in place, then they would do it at this time. Like what can be done if the patient goes into cardiac arrest, or this is where DNR would probably come into place, because if it's not going to improve the quality of their life, then patients aren't going to want the whole cardiopulmonary resuscitation to be done, because it's not going to prolong anything. Some patients don't want to be on a ventilator for the rest of their life if that's the only thing that's keeping them alive. So this is where those tough conversations come into place on this is what will happen, and whether your family likes it or not, it is a tough decision that has to be made. So, and sometimes it's best if the patient makes it because it's definitely happening to their body. And sometimes they may not be able to. So then there's usually some executor that would actually make that decision. But that executor would have spoken to the individual, hopefully, to say, hey, what are your last wishes? What would you like to see happen? So, so that palliative care would be like that months to years. And then end of life care is like weeks to months, is when you start seeing that the underlying condition is not getting better. So this is where, we hit that process with my dad, and then we kind of moved on. Yeah. So with hospice, this is where the person has less than or equal to 6 months to live based on their illness, or, but it's more of an approach to the care for when you're looking at hospice. So it's not really treating the condition anymore. It's more of, we're going to now, they either can go home or stay in a facility, and we're going to just provide comfort. So this is more of comfort care for them. So that is true. So yeah, that's completely different. But, during the hospice portion, they're in that actively dying process, and they may have, hours to days at that particular time, and then terminal care orders, like this is what what we will do afterwards. Yes, Elsa.
So is it the job of like the nurse who's taking care of the patient in hospice to organize the obituary, casket, all that, or is it more on the family, or just depending on the patient, I guess?
No, that's family, but I'm just saying during this time, these are things that family members will be doing or be encouraged to do.
Okay.
So when I talked about back when that first palliative portion comes in, now your patient may get there and they may be at the end of life. Does that make sense? I mean, they may be at that stage, but then now this means you're going to have to do it faster. but they usually have somebody come speak to the family. It's usually not the nurse. It's usually another entity that will come in, another physician that specializes in palliative care and end of life care. And they'll have that uncomfortable conversation. But as nurses, we just stay that support system. But it's just understanding what happens during that time. So you're not just sitting there, well, that's the palliative care people stuff, and I just kind of stay out of it. Because if the family asks you, you need to know what to expect. But you will receive, if you're a hospice nurse, you will now be a part of the terminal care orders. So, when the patient starts to exhibit, excess secretions, then we're going to use a scopolamine patch and put that on the patient. So you may be a part of that portion. That will be your care, keeping the patient comfortable. Does the patient look like they have that frown on their face and that they're actually in pain? So now you would give them the pain medication based on that. And hospice, the rules change a little bit because the patient may not be able to talk to you. So they start looking at the patient's facial expression to determine if the patient needs the pain medicine. So that will be their methodology to deliver it. So the care changes when we hit to that hospice component, if that makes sense. But palliative care, that can happen anyway throughout. But when the physician says there's nothing that we can do, and giving them this medication or treating them this way isn't going to improve things because the disease is taking over, then they'll hit that end of life and move into hospice care at that time. Does that make sense? Yes, Jessica.
Does the family make the decision for the patient to be put on hospice, or does the facility recommend it, or do they decide?
The facility will talk to the family and give them their options.
Mm-hmm.
So if the patient can no longer talk, then it belongs to the person who is the executor of hopefully the advance directive that's already in place.
Mm-hmm.
So that's how that would go. So the hospital just can't do it without someone's approval. Does that make sense?
Yes. Okay.
So, but death for kiddos and death for adults are completely different, but these are usually that stage, the palliative care, the end of life care, and then the hospice care or terminal care. But more adults are wanting to go home to die. They don't want to die in the hospital, too sterile, it's unfamiliar. They may have a shorter disease trajectory. There's usually less intense grief associated with the death of a spouse or parent, or, as compared to that of a child. They have several end of life quality measures that's available that they can utilize. And usually their symptom assessment and management is well understood and supported. Yes, Elsa.
I just wanted to ask if you have any personal material on preparing patients for writing their obituary, choosing casket, or the family, because this is a situation.
This is what we did because we had time. Okay. So there is it is recommended that those things happen. So when the physician came to me and said, there's really nothing we could do for your mom. And so what I would do is spend as much quality time as I could with her, and then start getting things prepared. Those were his words. The guy was really nice, though. He wasn't a butthole. And he goes, I wish that there was more that I could do, but there just wasn't. She was already at that terminal care stage. So, by the time I found out what was really happening, we were already there. And 13 days later, she was gone.
Oh, wow.
So this is why I said sometimes you just don't have time. Yeah. So, I didn't have a whole lot of prep time I didn't have that whole year like I did with my dad. And I, to some degree, felt a little cheated, but it was what it was. There was nothing I could do about that. So I can't sit there saying, what, I feel cheated. I feel robbed, but I actually had more years with my mom than I did my dad. So did I really get cheated? The answer to that is no. So yeah, there's just kind of things that you would do. What if you get a patient and they come in, say you're an ER nurse and the patient, is dead on arrival? What do you do? See, that's another piece. What is our nursing care related to patients that are, coming in, well, you just don't send them to the morgue.
Would you contact the family and like significant others, or that would be the first step?
We have body prepping. I mean, and especially the hospital policy is a patient that dies within your facility within 24 hours is a medical examiner's case, unless they have a terminal illness that was, the physician is willing to sign off on. But as far as our RN responsibilities, we need to make sure that, we're providing therapeutic touch and support as needed to the family, to the patient. Things to consider is calling the organ transplant coordinator, because, we don't know if the person is, even if we do know that they are, that we're still going to do the transplant coordinator. We need to call them. If we don't know, we're going to talk to the family to say, hey, this is an option. Or, do you know if this would be something that they would have one of their wishes or wanted to do? And then we would have to do body prep, post-mortem care, and take the family back there to see the patient so they can at least say their goodbyes for the individual. So there's, those are things that you would do in the emergency room. So if you get there, they usually get treated the ER physician will do an assessment to see if there's anything additional they could do to help this person. And then if not, they'll call the code or call the patient's time of death. And then the next piece starts. So again, that 24 hours is golden. You don't take out any IV lines or anything like that. You disconnect like the Foley catheter and you tie it off at the end. But you don't take it out of the orifice. You leave all that stuff in. And you just, clean up the body as much as you can. So, if there's blood and all that, because you want to make them presentable for their family member. You don't want to have, bloody face and that business going on. And you put on a new clean gown, make the bed underneath much neater. So new sheets. So that's kind of the stuff that you would do. Your hospital usually have a chaplain that or some other person. When I worked at Methodist Medical Center, we had a chaplain that would come in, and he basically did a lot with the family. He was our liaison between us and the family folks. So he would communicate their concerns and needs, and then we would provide information. And as the patient died, then the nurse taking care of that person would go in with the ER physician along with the chaplain, and we would tell them the whole situation from start to finish. Then when we started allowing family at the bedside or family in the room, then that kind of alleviated that piece there. But we instituted that realm with family at the bedside, that they're present during the dying process if this is what was going to happen. So as far as like their belongings, yes, nurses collect belongings, but we're not responsible for the disposition of the belongings. And what I mean by that, that's usually going to be whoever that was the chaplain's responsibility. So we would give him the clothing, he would pass it on to the family, but we would have a list of what was in what we had, and this is what we would give to them. So this was all of their personal effects. So that person became he was the liaison. So, care of the family is what we're responsible for. Maintenance of the organs, which may be used for transplantation. The physician is going to explain the client's status and the cause of death, because that's out of our realm. Social worker is usually involved. We actually had the chaplain, but most people use social worker to help coordinate the funeral director and the disposition of the personal belongings. The rest, outside of taking the body to the morgue, that's the only responsibility we have, in addition to calling the medical examiner and getting a case number and adding that onto our records. But we don't deal with the clothing component to that level. We leave the tubes in just to make sure that the IVs were patent. So that wasn't the reason why the patient died, is because, the IV was infiltrated and we're still giving stuff through it. We left in the ET tubes to make sure that the ET tube was in the right place, and it wasn't, in the esophagus instead of the trachea. And then if we had to leave all those things in before we brought the family in, we let them know that, what they would see. So you should always do that. Let them know what they would experience in the room. So we didn't at Methodist Richardson, we didn't do what? Leave the tubes in? Oh, okay. That must be their policy. When I worked at Methodist Dallas, and I don't think that's changed, and it may have, but everything stayed in. So if the patient has a terminal illness, then there's no need for it to stay in. But if this was, we don't know why the person died, or if this was a GSW, or if this was a stab wound, then all those things are going to stay in. But if it's a terminal person, no, you don't need to leave that in. So, you know, we were talking about a person brought in and we don't know the true cause of death, and there's no one to say, hey, you know, this is a terminal case. But if you have a terminal illness person, then that physician will be called to say, hey, your patient came in. Okay, there we go. All right. So we have about 10, 15 minutes before Ms. Smith should be logging on to do PDEOL or PD end of life. Questions before she logs on? Do you feel like you need a 10-minute break, and then by the time she logs on, you'll be ready? Okay, so study session this Saturday starting at 10. And, you know, okay, so with ALS, basically, and this goes into end-of-life care and terminal illness. With ALS, what this is really about is what to expect as the patient starts to decline. So at some point, they'll be on palliative care, go to end-of-life and terminal care. So that's what that's really about. The process with an MI has to deal with the grief of the MI. What type of lifestyle will this person have post? Then the grief becomes, will I have another heart attack? Will this be worse? Will I be able to, you know, survive it? That's what that was about. So it's how, when you have these symptoms, where's the grief in that process? So if you have ALS, where's the end of life in that process? Well, as we know, this is a progressive degenerative neurologic disease. And I don't know of anyone that has survived past 5 years. So past 5 years, usually that person, within 5 years, the person usually ends up dying. And the percentage for folks living post 5 years is about 5%. So at some point, they're going to hit this palliative care, end of life, terminal care process. The difference between hospice and palliative care, they'll do some treatments. And, you know, so say, for instance, if the person has cancer, then they'll do some radiation and or chemotherapy. When in hospice, there is no treatment, but it's all comfort care, management of symptoms that they may have. So if they're vomiting, then give them an antiemetic. So it's more supportive care as they transition through or transition into death. So that's the difference between palliative care. So they're not really trying to do big measures to satisfy or to treat the disease condition. To clarify emails of, okay, we'll deal with that at another time, but let's talk about this. And both can be done in any location. So yes, that is true. You can do them at home because some patients, and especially adults, they'll choose to go home. Kiddos, it's a whole nother ball game. But the conditions that are listed under end of life, and I'll be more than happy to make sure that it's crystal ball clear, it's these conditions related to either palliative care, end of life care, or terminal care or hospice care. So that's why these conditions, you would see these folks transition into these positions. Does that make sense? So if you had a SIDS baby, then that life portion, I mean, there's no warning sign. So it just happens, right? There are some suggestive things like, you know, the baby was on their stomach and versus on their back, or maybe they got wedged in between, you know, the pillow and the mattress in the crib. So there's some suggestive things related to that, and also suggestive from the standpoint of the mother and what their lifestyle was prior to. So when you're talking about grief, it's like if you had a SIDS baby, how would the grief be for the family? And then I can't leave without saying the grief for yourself. because some of these folks you're actually going to, be tied to or have some feelings about, and it is not uncommon, and there's absolutely nothing wrong. That is actually appropriate when you do, it's okay to cry, but remember, don't cry more than the family. You do want to make sure that you are human, and those things are going to touch you. So don't spend time trying to be stoic about the situation. Does that make sense? So when those conditions are listed, that's what it's really about. It's about how these things impact, what actually happens in ALS. What do you mean? Oh, there is inpatient palliation. Clarify for me, Kristen.
I just meant, like, hospice is usually, not usually, but can be done like in a hospital setting.
Yeah.
Inpatient setting, is that the same for palliation? Is it like a long-term?
Okay, so palliation is the relieving of pain, but palliative care, and this is semantics, but I need you to separate the two. So palliation is alleviation of pain. So that's what that is. So comfort. And it's easy to say it's palliative care, but it may not be, because it doesn't have to be related to a terminal illness when you do palliation. Does that make sense? It is a fine line. That's why I said it's semantics. That's why I started with that. If they think they're going to die within a few days, they will do inpatient hospice, yes. On a med-surg floor, yes, they will do that. There's no sense of sending them home, getting all those resources set up for the patient to die within the next 2 days. So yeah, they'll keep them there, and they'll move them to a floor that if the hospital provides. Some hospitals may have a end of life or palliative care floor that they go to. Some of the larger hospitals. So if not, they'll just move them to a med-surg floor, put them in a private room, and the family can go in and stay in as much as they want to. And then they can, spend time with their loved ones for the last few days they have left. Yes, it'll be recorded. The study session will be recorded. So I'm trying to see other things. Mothers that smoke during the pregnancy, passive smoke can also increase the risk of SIDS. Having a baby before 20 years of age. So basically pregnant before 20, so like 15, 16, 17. No prenatal care or very little prenatal care. Low birth weight babies are all prone to SIDS. And they have a risk for being a SIDS baby. So does that answer your question, Jessica, about how does that play into end of life? So you're looking at these conditions for which, they will be the person's end of life, or where they can receive some treatment, but they may not be able to receive a lot of treatment.
Yes.
And then they'll transition to the next piece.
Yes, thank you.
And remember, this is an interdisciplinary process. So you're going to have multiple folks, and some folks' roles you may not understand, and some people's roles you may clearly understand. But, educating folks on what to look for as they transition, if they're actually at those last few days, their respirations will become slower and more drawn out. Their heart rate will start to trickle down and become more slower and more weak. And they stop taking blood pressures and things like that. So, sometimes they'll leave it up there just, for family's sake, so they'll know that what's getting ready to happen. And sometimes the family don't want it up there. So it's all individual. So there's not a one size fit all. Death rattles, yeah, that's the extra fluid that they start to secrete. And that's because they're losing that ability, like to swallow, and they're losing that ability to manage secretions. Right. So understand how this disease will lead to this death. Does that make sense? So not necessarily if you have a heart attack, this is how you treat it. It's like if you have a heart attack, what's the grief related to it? Any other questions? So will 10 o'clock start time on Saturday work for you guys? Okay. So I will give you a 10-minute break. Be back. Actually, it's going to be less than 10, so a 9-minute break. So be back at 10:15 for Miss Smith. You are welcome. Yep, that is true. It'll be loaded to the group YouTube.
Miss Hudson, are you guys on break?
They went on break about 10, and they're waiting on Mrs. Smith. She's supposed to be on at 10:15.
Got it. Would you like me to text her and see where she is?
That would be helpful. I've sent the same text.
Okay, I'll text her. Thank you.
Uh-huh.
I just heard back from Miss Smith and she said she's coming. I asked her for a time so we would know what's going on, and she has not responded to that as of yet. It looks like Ms. Smith is joining the session now. Guys, I'm sorry you had to wait.
Good morning. Are there?
But
I apologize for being late, doing a V visit with the physician and my sister. So can everybody hear me?
Ms. Smith, just 1 second. Guys, I really owe you an apology for the class being late.
Okay, there you are.
so-
Good morning, Stephanie. So we're going to finish up with pediatrics and end of life. Excuse me. So there is the PowerPoint we looked at last week with intracranial and hydrocephalus is at the end of that is the end of life. So you can look over that. So looking at the pediatric component for end of life is how does that differ when from looking at those older people, middle-aged people, or the adult community? So again, looking at that, what are some of the, trying to think of the word I need, the differences, what are those differences when looking at a child at the end of life? Who are you including in that? Yep, the parents. Yep. And do we need to include siblings in that? Oop. See if I can get my chat thingy to come up here. Can't see my chat, but so we're looking at the parents, also siblings, grandparents. So as with adults or other people that are dying, the whole family is involved, but it can make a significant impact on the family as they're dealing with that dying child. Children, the siblings many times feel left out because the focus is on that dying child. Marriages many times have difficulty surviving once the child has passed away. And when we look at adults that are dying, do they have an understanding of their life expectancy and what's going on with their health generally? Yes, adults do. Ms. Smith, please put your, I missed that comment. I'm having trouble getting my chat thing to list for me. I'm on a different computer today. There it is. Oh, I thought the video was on. I apologize. There. Okay. So
now you're sideways.
So with children, they may or may not have a perception of what's happening. If you have a child that has chronic illnesses, you'll read many studies or comments that the child is aware of what's going on, has gone through multiple rounds of chemo for their cancers or whatever, and understand that their end of life is coming. It looks like your connection is poor right now. Please mute your microphones. So anyway, this is crazy. I'm sideways here for you guys. I look like I'm upside down. I know I saw that I was sideways, and I'm not sure why this is not my computer. Did that get me right side up? So my other computer is in use by somebody else. So I apologize. Let me see if that'll come back on. It's still sideways. Interesting. Audio is horrible. Okay, as soon as my computer is free, I to that one. Let me log out and see if I come back in, if it gets better. Hang on a minute. We'll be right back. Okay, well, I'm still sideways. Is the audio any better? No. I'm so sorry. Okay, I'm going to turn the video off so the audio is better. Is that somewhat better? I turned the video off. Maybe that'll do a little bit. All right, so we were talking about children that are chronically ill. Okay, the PowerPoint that I was referring to is in intracranial, and it says hydrocephalus and end of life. So at the beginning, it goes through the pediatric intracranial signs and symptoms of intracranial pressure and things in the pediatric population. Then some information specifically about hydrocephalus. And the last 8 or 10 slides is on end of life. And there's a case study, some case study questions. And one of them is, and we were going to discuss it, is if your child is saying they are going to see their grandparents, their grandmother is coming to visit, she's going to see them soon, and grandmother died 2 years ago, how do we handle that comment? Please call in. Okay. Dean Becker suggests calling in, so let me do that. So let me get back to our dial-in thing.
Welcome. Please enter your conference number followed by connecting.
Are you there?
Mrs. Smith? Miss Smith,
Yes.
you got to turn off your sound on your computer now if you're going to have your phone on.
Okay, let me, although I can't see too much. All right, did that take care of all? I have a terrible feedback.
There's still an echo. Yeah.
Yeah. That. Let me turn that off.
Did that take care of it? Are we all still there? I hear lots of dinging. Is anybody still there? Okay, and I'm off, so I can't see all your comments. So, yes, let me see. So y'all need to talk to me. So if you're if you have that child that indicates they are going to see a departed loved one and the parents don't want us to discuss the fact that they are terminal, what is our responsibility as nurses? Can we have that conversation with the patient?
Wouldn't you need to encourage the parents to get to that
Right.
point?
If the parents say don't tell the child anything, we cannot give that information to the child. If the parents are unaccepting of the outcome or the expected outcome of their child's illness and doesn't want to discuss that with the child, what are our options as nurses and the medical team?
Maybe bring in a therapist or a counselor.
Okay, a therapist or a counselor, and possibly a conference, a patient conference with the family to identify what their concerns are, help them with their acceptance. One of the things we had talked about last week was the child at Cook that was terminal, and the courts and the parents did not want to take her off life support. She's a year old, and the courts did rule, I think at the end of February, that the Cooks could take her off. I didn't get a chance to finish reading all the articles to see if life support has been terminated for her. But again, what is their quality of life? What are those expectations so that the parents can start working on that anticipatory grief, obviously, but also preparing the child and answering their questions. Many times children will say to you as the nurse, am I dying? Or I know I'm dying and my parents won't talk to me. So again, trying to bridge that gap, have that conference with the parents, telling them what the child has said, and they may say to you, I know you'll tell me the truth. So how do we do that therapeutic communication with our dying children to find out the information and give them the support they need without overstepping and telling them things that the parents don't want us to. So we get into that ethical dilemma as how are we helping the parents and still honoring their wishes with that child. We still need to do all the comfort measures at end of life that Ms. Hudson talked about with adults, identifying when they're getting close to end of life. But in children, many times we will do palliation as well as doing things to continue life and to help them with their disease process. So remember, somebody's got a terrible buzz.
Ms. Smith,
Yes.
I think that if the child is also verbally, I guess, for lack of a better term, accepting that they're dying and that they're worried because their parents won't speak with them, I think that would be a good time to possibly engage the parents all together with the child in speaking about it.
Absolutely, and that's one of the big things is many times the child is aware and they want to make that peace with their parents and be able to tell them goodbye and things, and they are not given that opportunity as the parents will not engage that conversation with them. So trying to get them into the room and on the same page, so to speak, so that child can talk to their parents and do that final acceptance. Remember our 5 stages of grief? The child may be at acceptance and the parents are not. So how do we help them get there so they can have that final time?
Right, and I think that in that case that the child can actually help educate their parents.
Yes, absolutely. There's no particular exemplars for pediatric end of life. It's just looking at what are those differences, looking at their developmental level. Remember, when we're talking to siblings and things, using proper terminology. As younger children don't understand the concept of death, so telling them that their brother or sister has gone to sleep, that may make them fearful and they don't want to go to sleep because they don't want to not wake up. So using those correct phrases as working with them, and I apologize for the feedback. Kind of lost without my script, so with that. Still doing those comfort measures. Again, I was talking about palliation as well as interventions to improve their health, if at all possible. Whereas usually we do palliation in hospice. Hospice is no more care as far as treating the cancer. They stop chemotherapy and things. With children, we'll do the palliation and continue their cancer care until the parents decide to discontinue that. Does somebody have a mic open that's causing all our feedback? Questions for me? Oh, very quiet. Okay.
Kind of hard to hear you.
Yes, I understand. Let me go see if my other computer is free yet and get on with that one. Hang on a minute.
Okay.
Guys, I've just emailed Miss Hudson to see if there are any supplemental material that she can give you for the content for today. Since you didn't have your full amount of time, and with class being over at 11, that you didn't have your full amount of time for end of life or hydrocephalus. Once I get it from Miss Hudson, she's looking something up right now, and she will post it for you once she gets it, so that the content will have been covered in depth for your exam.
Okay, and I'm back on, and we did cover hydrocephalus and meningitis quite thoroughly last week, Dean Becker. So the end of life was just at the end of that presentation.
Miss Hudson just texted me back and said she'll do a Zoom session with all of you, and she'll send that information out either later today or tomorrow. And she said to please make sure you come with whatever questions that you have, so she can address your questions first and then go from there.
Okay. And if y'all have any questions, you can, I'm happy to entertain questions as well, and review over the case study that's in the PowerPoints, and I will send that out as a separate, break it out from the hydrocephalus and send that on to you as well. And I guess the audio is better now, although my video is not coming up for whatever reason. Let's see. Trying to look to get back to those PowerPoints. Other questions? Now that you can actually hear me without all the squealing and feedback. Left the session. Okay. Trying to pull that up for you. Oh, there it is. Come on. So this is the PowerPoint
in the chat room that they want to know is lecture over.
I was trying to find, this was what we had seen last week, so I was getting this as that PowerPoint. It's in your files. To look at end of life, that case study I was talking about. That's the shunt revision. So yes, we can be done. Send me your questions. Here's the, like I said, here is the end of life ones, palliation. What's the goal for the patients? Yes, Kristen.
I was going to see if maybe you could open up one of those session boards like you did before, where we can all go in there and ask questions and see each other's. Maybe that would be helpful.
In the classroom or a discussion board?
Yeah.
Which one?
I don't remember how you did it last time. You just made it before the exam. If we had questions, we could post in there for a few days, and then you would answer them so everybody could
Sure.
see everybody else's questions? Okay.
Absolutely. Any other suggestions or questions? Yes, Alexis.
I had a quick question about PNC. What do we do about our PNC hours? Do we not need to submit those this semester, or?
If you've done your PNC hours, please submit them. If you have not been able to get them, we were not counting that against you. So if you've already done them, I know Mr. Bobbitt is doing El Centro's group. But if you've done them, please submit them. But obviously, we're not requiring you go out and getting them at this point.
Okay.
Any other questions? Did you have a question, Jessica?
Yes, I wanted to see if you were able to see my email that I sent you a week ago.
I did not see that. Did you put it in the class or directly to me?
I emailed it directly to you.
I will search for that, Jessica. I did not see that at all, but I will go back and look for that.
Okay.
Okay, anything else? So, yes, Alexis.
Our PNC exam is on Wednesday at 11. Is that correct?
That I will have to confirm with Ms. Hudson.
Okay.
Anyway, so this isn't the, as I said, the PowerPoint that's there in our intracranial. This is the palliative, as I said, concurrently given with life-prolonging care in children and hospice. Okay, and when we were talking about the earlier one that he's seeing his grandmother, so as Ms. Hudson is going to do a Zoom session, if y'all don't have any additional questions, I will let you go. I'm sorry for the poor quality from the other computer. Amazing how computers make that much difference. I will put up a Blackboard for discussion, questions. And remember, we have the question and answer next week at 9 o'clock on Wednesday to, again, bring your questions about any part of the semester to help you get ready for your comprehensive. Any questions? All right, I will get that Blackboard discussion board up for you.